Apologize, you guys. So good morning, everybody, and thank you for joining us today. My name is Charlotte LeBay, and I'm the Senior Administrative Coordinator for the California Primary Care Association. On behalf of CPCA, we want to welcome you to today's online training, Addressing Healthcare Challenges for Pregnant and Birthing Patients through Telehealth. As a reminder, today's session is being recorded, and you will receive the recording link and the material within 2 to 3 business days. Some of the webinar tools that we have for you today are the chat function, the raise the hand function, Q&A, and show captions. If you would like to raise your hand to let us know to unmute you, you can do that as well. You also have the option to react to some of the comments that are in today's session. With that, I'm going to turn things over to Ekema. I apologize for the delay in getting started, but thank you all for joining.
Thank you so much. And thank you all very much for joining us this morning to discuss how we can address the challenges that are faced by pregnant and birthing patients. So as we know, the COVID-19 pandemic affected the way pregnant and birthing patients receive services and care, and also highlighted the need to focus on this special and vulnerable population. So many of you know pregnancy outcomes are influenced by both system-level factors as well as social determinants of health, such as lack of financial resources, availability of transportation, housing stability, lack of social support, lack or limited availability of healthy foods, and even factors such as institutional and structural racism. Pregnant and birthing patients that were already at high risk for poor pregnancy outcomes because of any one or combination of these factors were at an even elevated risk during the pandemic, especially as in-person services diminished. Healthcare providers kind of strive to provide a continuity of care by quickly pivoting to other care service deliveries, such as telehealth. So how can we as health center providers continue to serving in this in our underserved communities, continue to develop strategies and leverage partnerships to be more efficient and effective in caring for pregnant and birthing patients, whether during a public health pandemic and even beyond. So doing so, as we know, is really essential to kind of improving both the psychosocial and the clinical outcomes for pregnant and birthing patients. So we'd now like to kind of turn the floor over to our speakers that are going to be talking about what we can do to kind of leverage telehealth and to improve the services that we are providing to pregnant and birthing patients. So our guest speakers today, and we're really excited to welcome them, are Sigi Marmorstein, who's a nurse practitioner, CEO and founder of Baby Life Advice, as well as Dr. Faustina Nevares, who's an OBGYN currently working at AltaMed. So I'll start by introducing Sigi. So Sigi is a telehealth consultant with over 60 successful telehealth implementation projects. Her role as a telehealth consultant is a culmination of a 20-year career in healthcare, spanning employers such as DaVita, Kaiser Permanente, USC, Adventist Health, and West Coast University. Sigi has years of experience in the healthcare industry as an emergency room provider, operations manager, project management, business owner, as well as in academia. And she consistently throughout her career remained devoted to finding solutions to improve patient access to care. So I can go on and on with all of her accolades, but I think we'll, for the sake of time, we'll kind of leave it there. And I would like to now introduce our other speaker, Dr. Nevares. So Dr. Nevares completed her undergraduate degree at UC Davis and obtained her degree in medicine from UC San Francisco. She completed her residency at Kaiser Permanente Los Angeles Medical Center. And after 40 years at Kaiser Permanente, she retired and is now working at AltaMed, I think the largest FQHC, in the country, right? So Dr. Nevares was born in Mexico and grew up in Northern California. And though she's a mother to 2 children, she still finds it a miracle every time she sees a newborn child come into the world. She is serving as an OBGYN at AltaMed, and we will be talking with us today about their experience in providing services to pregnant and birthing patients via telehealth. So I'd now like to turn the floor over to Sigi and Dr. Nevares.
Thank you so much. Go ahead. Thank you so much for the CPCA for bringing us to speak about this wonderful program that we have been started with Dr. Nevares and AltaMed, and how we were able to address the challenges in supporting pregnant and birthing people through telehealth. Let me see if we can just go on in here. These webinar objectives are really been stated before. I don't want to repeat them, but in general, we hope that at the end of this presentation, you guys will be able to understand how you maybe develop some strategies and telehealth strategies in caring for your own patients, as well as understanding the cultural, language, and other barriers that exist within the Medicaid population, and how to better serve them with different kind of innovative modalities. We know that California is not doing too great, but better than many states in the United States in grading on preterm birth and also infant mortality rate. California as a state has done a tremendous amount of work in supporting birthing people throughout their pregnancy and in the postpartum era by programs like the Nurse Family Partnership, Welcome Baby program, the CPCA, the CPCA program, and other programs like that. And due to that, we are actually the leading in the infant mortality and birthing outcomes in the United States. But altogether, the United States is not doing that great in birthing outcome or infant mortality. We are actually rated as number 58 in the industrial world, and mostly, and where we are failing the most is in the BIPOC community, with Hispanic and Black women suffering the worst outcomes in maternity. California in 2021 had a total birth of almost 450,000. We know that number is actually decreasing from years prior, with about 46% or maybe 47% of those births are being under Medicaid. California policies has been updated constantly around COVID, as well as around different maternal health policies. And some of them are being already in motion. Some of them are coming through. The most important one is the expansion of postnatal care into the 12 months period, both for CPSP and all Medi-Cal access programs. That means that for all FQHC and primary care providers, there is going to be an expansion of the requirements and to meet for those birthing people and their infants. More care for a longer period of time. We also, knowing that there's going to be an end to the mandated enrollment, where most managed care plans will have pregnant women that are in a certain income level mandatorily enrolled into the Medi-Cal program, starting actually right away. So that will bring about 700,000 new Medi-Cal covered population, as well as about 250,000 childbirthing year women into Medi-Cal by the end of 2024, which definitely will increase the amount of patients that will be seen under the FQHCs at that time. There's also a very big focus on reduce of health disparities, creating dashboard that shows how you are meeting and dealing with health equity disparities as it regards to the BIPOC community, which will mean Hispanic and Black patients specifically, but also how are FQHC showing mental health, how they're dealing with cultural competency, substance abuse, alcoholism, and gaps in social determinants of health. Those are going to be now kind of watched for by Medi-Cal as they are looking into contracts for the following years with organizations who can actually meet and reduce health disparities in their organization. We also seen a wonderful new initiative that will start now in January of 2023, which is the doula services that will be covered under Medi-Cal and should be offered to mothers under the regular care by the FQHCs and the medical providers who are caring for them. I'll talk a little bit more about the doulas and what is their role in the maternity journey. But with all this exciting news, there's also means that there's going to be more work and higher needs in the FQHC levels. We know already that the medical eligible patients can receive, of course, it's not mandatory, this is voluntary, CPSP services. Those services are should be offered by CPSP providers in the state routinely to all mothers who are eligible, to provide them with case coordination, client orientation, obstetric, of course, services, but also nutritional, health education, and psychosocial services. Those also are being done in trimester assessments that are lengthy assessment that look at all the different aspects of the mother's health, which starts in mental health all the way to dental health, nutritional services, social determinants of health, and everything in between, with interventions that are pre-prescribed interventions that can be given by any CPSP provider. With it now, with the expansion of CPSP services, we know that services postpartum are also required, by which those will be including lactation, addressing social determinants of health, addressing postpartum mental health disorders, and others as such. Medical eligible CPSP patients, if they were to meet all CPSP services, will have to come into a clinic 23 times throughout the pregnancy and another 12 times postpartum. And we know that that is a challenge for those populations in receiving and meeting CPSP services. The FQHC challenges in maternal infant care are growing for many reasons. The growing number of patients, the staffing challenges, those are true across the entire United States, but also here in California. The no-show rates, again, related to the fact that women have to come back maybe 23 times to receive all of their services. If you take that between that and WIC and other services that are available to them, that's just a lot of appointments. We've seen older and sicker population. Women are getting pregnant later on in life. By then, they may have developed many chronic disease, may have even other mental health, social determinant of health issues. All of those are barriers that the FQHCs are dealing with on a regular basis, caring for this population. The reduced care access, the amount of appointments that an FQHC can possibly provide between the hours that they are open, is also a barrier and challenge in serving this population. We also know that there's barrier to care on the patient side. And those are not just on the patient side, but also on the organizational side. Adequate care in maternal care really requires availability. And not just talking about available in respect of just hours of operation, but also geographical location. How far are you from the patient home? And what does it take for the patient to get to you? How accessible are you to this patient? The appropriateness of the visit, and what does that really mean? Do you have the professional and technical capacities to care for the patient in a timely manner? Or do they have to sit in your waiting room for 4 hours? Do you have the language that the patient is speaking within your organization? Can a person who's caring for them speak in their language? How affordable is this care for them? How easy it is? Affordable means, can I have transportation? Do I need to have childcare? Do I need to have any copays? How many buses or how many trains, or what does it take for me to get to your organization, and can I afford that? Affordability also means, am I losing a day of work? Am I losing pay in order to make my appointments? If that's the case, I might not want to go ahead and make that appointment. Approachability really is, again, about how do I feel about my physician or my care provider or my nurse practitioner? Do I feel that they are approachable? What is their attitudes toward me? Are they welcoming? Do I feel comfortable with them? Do I want to tell them my life secrets? Or do I feel that I just cannot tell them anything? And lastly, of course, as I said, acceptability. And this is where we're hearing a lot about patients who are experiencing social racism or racism in general within the health system, when they feel that they are not being appreciated on the cultural side, that the tradition, their own personal values are not being respected, and that they are not being respected on the gender norms. We will talk later on, but we have a lot of patients who are from the gay or lesbian community, transgender or others. Maybe they do not feel that they're being truly accepted when they walk into a health organization. All of these barriers and, are really resulting in the outcomes that we are seeing in our country, and especially in the BIPOC community. Again, increased no-show rate related a lot to the fact that if I'm not acceptable, approachable, affordable, and appropriate, I will not show up into your organization. Reducing engagement and compliance, that means, again, if I don't feel that I am being respected, I may not engage in healthcare, I may not follow my doctor's order, I may not actually be compliant with what it is that I've been asked to do. With that, then I'm increasing the risk on myself, and of course, my physicians have to deal with a higher risk patient who is not compliant and not showing up to their appointment. That creates preterm birth, C-section complications of the pre and the postpartum era, increased stress and burnout on the providers. We're hearing a lot about something called quiet resignation. Quiet resignation means, yes, I am in the clinic and I'm sitting here, but I'm not involved. I'm not motivated. I am not doing more than I've been asked to do. I'll just do what I need to do to just get through the day. And so we've seen a quiet resignation is a big pandemic that we are dealing with right now in healthcare, where providers are not going above and beyond the rule and expectations. Readmissions and complications that will result from all of the above, with ultimately, untimely follow-up, again, due to lack of appointment. And in the end, FQHCs and others are not meeting the guidelines and the contracted services that they're contracted with Medicaid for. And that is where we're seeing a lot of gap in care. Evidence-based models have been around forever. WIC is one of them, of course, but of course, there's also the Nurse Family Partnership, Welcome Baby. And of course, there's very strong evidence on the doula support within pregnancy in reducing all of those complications I just spoke about. With the Nurse Family Partnership and Welcome Baby, patients are receiving care all throughout the pregnancy by a nurse coming to their home and supporting them all throughout the pregnancy and up to 12 months of age. As you can see from the evidence, it really does help in reduce of many complications. And we've seen fewer preterm birth, pregnancy-induced hypertension, preterm deliveries being reduced, reduction of very close spaced births, which is have a lot to do with education, child abuse and neglect, and of course, we've seen less injuries in the first 2 years of life for infants. Of course, doula support, which is really, again, educational, social, mental health support, is shown to reduce C-sections, increase likelihood of spontaneous vaginal birth, and definitely have shown shorter labor with women who are feeling more supported and satisfied. What is the problem then? We have great evidence-based practice. Why can we not just unleash it on everybody? The Nurse Family Partnership and Welcome Baby program are being sponsored right now in California through the tobacco tax. They are experiencing shortage in actual funding over the years. They've been really shrunk. And so they can only care for very few and far between people. Doula, although they have been showing great outcomes in the state of California, finally, we're going to see them being supported by Medi-Cal and being reimbursed by Medi-Cal starting of next year. But until now was not a reimbursable services. And so a lot of people were not using them. What can we do is then take services like this and try to replicate them in a different way. In doing them more virtually, we allowing to reduce the costs associated with this program, but keep the outcomes the same. So before we talk about why telehealth and alternative methods, I wanted to have Dr. Nevares speak a little bit about AltaMed and how is AltaMed working with birthing people under CPSP.
Well, thank you, Sigi. I'm really appreciative of the Primary Care Council and Sigi for inviting me to talk about AltaMed. As you saw from my bio, I was very involved in a very large organization. I was a chief of service as well as at a tertiary care center, and as well as helped run the Southern California portion of OBGYN for a few years. So what am I doing in FQHC? And it's kind of important to understand this FQHC, who now is one of the largest in the country probably, started out as a barrio-free clinic with the old Brown Beret and the Adelitas about 55 years ago, more or less, and just a storefront community center more than health clinic. There were no physicians and there were no nurses. It was just the community kids, really, who said, you know, we need healthcare. And from there, they would see sick people and they would be advocates more than anything else. And that's how it grew after Castro de la Rocha, who was a lawyer, not a doctor, came by and organized the entire operations. And now we serve probably about 400,000 patients, 300,000 which are in the FQ, half of course are women, and more than a third are of reproductive age. So we're seeing probably in pregnancy or some form of shape, if not partial or complete, somewhere between 300 to 500 pregnant patients a year, and we're delivering about 3,000 patients per year. It's spread over 2 counties, Orange County and as well as Los Angeles County. And so I'm a country girl. I grew up in Northern California, a little town called Arbuckle. I know what not having healthcare means. I know what it means to have to travel. I know rural health. Even as an undergrad, and I would work in rural health clinics. So I knew what it was about. I did not expect to have very similar situations in the middle of Los Angeles. And those of you who live in that area are saying, what is she talking about? Well, I can tell you that from where we lived, and it's a small town, we're talking less than 1,000. We were driving a good half hour to an hour to get our healthcare. Now there was one GP in town, but for pregnancies or hospital care, we had to drive. In Los Angeles and Orange County, I can tell you the commute to these facilities is about the same. It's about 30 minutes to an hour in most of the times during the day, because that's just how it is. For our population here in AltaMed, and it's an amazing population, and I feel incredibly lucky that after having worked for 40 years in healthcare, to be able to come to AltaMed. And I'm really excited to be able to bring the types of experiences I have to AltaMed, but it is a challenge. And it's not unlike the challenges in rural America. And it's not with regard to, excuse me, with regard to proximity to healthcare, and as well as transportation. We have in OB about 90 to 95% Medi-Cal. Obviously, they're young women and they're poor. And it's really kind of incredible that we have the outcomes that we have, and we have very good outcomes, or reasonably good outcomes. Most of our population is Hispanic, and that is probably one of the biggest reasons. It was interesting to try and put together, because when I came here 3.5 years, there was no OBGYN department, everything was contracted. But now we have 14 OBGYNs, we have 12 mid-levels, and 3 advanced women's health providers. The issues that we have remained with the patients, even though AltaMed has strategically placed the clinics where our patients live. Our patients, and I love the quiet resignation, our patients would come and get the health care at the clinic, even their entire health care. But should we have referred them out, they did not show up. there was something to say about that quiet resignation. Most, unfortunately, of our MFMs, et cetera, were on the other side of town. And to go to the hospital, to come back to our clinics has been quite an issue, and we're still working on that issue. Partnering with Sigi brought a lot of help to the space, the transportation, and the cultural appropriate care that we have. We have assigned our classes to Sigi, not 100%, we do our own as well, but we think, and Sigi will show you some of the data, we're getting excellent outcomes, because I do believe that we are in a situation where women are more likely to be honest and speak, men too, I guess, on the phone, on video, than they are maybe even face-to-face. The face-to-face visit is important. The hands-on is important. But honestly, for the teaching, for really getting that information that we need, women have to feel comfortable, and they have to feel protected. And for some reason, the phone seems to, or the video, this technology seems to have brought a lot of that work out. So I'm really happy to talk about how well this program, now did we look at other programs? We'll talk about that towards the end and have some specific questions. But I will let Sigi continue and bring forth some of our outcomes, because I'm really, really proud of this work. This is truly an underserved community. It's a difficult community to bring healthcare to. And I think that the telephone and the video visits, as they work in Los Angeles and Orange County, which is a sprawling metropolitan, is just as challenged as rural America. It truly is. And I know you don't believe me, but it's true. Yeah. Sigi, go ahead.
Thank you so much, Dr. Nevares. I appreciate this input. So quickly talking about telehealth, FQHC were not able to provide actual telehealth services until September of 2021. What changed at that time was the law that has changed in telehealth due to the COVID emergency order. Currently is extended until January 11th of 2023. So we'll see what that looks like. But the reality is that in California, there is an extension of telehealth laws to provide care under telehealth, which is video and phone, to 2025, which is really wonderful, because it's allowing a lot of FQHC to enter into more and more telehealth services and allowing them to provide care differently than the face-to-face meeting. Here is a really good care delivery model that has actually been studied at Kaiser. Kaiser has really been, and as an organization, in the forefront of telehealth back well into when I started with Kaiser was 2010, we were already doing phone visits. And now, of course, 40% of all primary care services at Kaiser are being done via telehealth. So this is a great chart that shows the different capacities that pregnant person can receive over telehealth safely. It's been studied by the Kaiser organization to show multiple services in the perinatal and the postpartum era that a patient can receive in telehealth. Bringing this to AltaMed was really the vision of Baby Life Advice very early on, is to replicate a model that has been done at Kaiser in maternity care and bring it into FQHC the moment that we were allowed to do it, which was back in September of 2021. Well, let me tell you a little bit about the Baby Life Advice. I'm sure a lot of you are hearing Baby Life Advice, and nobody knows who we are and what we do. Baby Life Advice is an organization that I have started back in 2014. We have served about 50,000 women all over the United States via telehealth, from preconception to early childhood. The idea of the Baby Life Advice was to use easy to access technology with services to support current health practices. That means that we did not want to go against what already has been done, but really just augment it, and bring it into the patient home. The idea of Baby Life Advice, or the mission of Baby Life Advice, is to serve women and babies everywhere and anywhere that they are at. This is a centering pregnancy concept that's been around for a very long time, and it allows us to really support women and babies at their home. Doing so, we have an engagement solution, which is a technology solution that we have developed, with integrated into services that are supported by nurses, nurse practitioners, doulas, lactation consultants, mental health providers, and others. The idea here is to keep the parent in the medical home, whether it's the FQHC, Kaiser, or any other place, but support and surround them with services that otherwise would have been taken 23 times to get into a clinic to do. Ultimately, resulting in better outcome, reduce risk, and improve access to care. Just to talk a little bit about the services that we are being able to provide are the virtual 6 and prenatal and 6 postnatal consultation that are covered by CPSP. The group classes in education, birthing classes, welcome baby, infant CPR, and other, again, covered by CPSP, all done virtually and all done live, taught by a nurse practitioner to the patient in their language. Nutritional services, both in group classes and individual support. Mental health services, PHQ-9 screening, mental health support group, and individual support. Diabetes education, those can be done in a group as well as in individual support, reducing the need for MFMs, especially in the communities where MFMs don't exist. Our group education in diabetes really follows the Sweet Success program. So very much as Sweet Success, only it's individualized and in the home and done through Zoom. On the postnatal side, Baby Life Advice can do the first postpartum visit for mom and baby, checking them for mental health as well as physical health, assuring that baby and mom are safe, that there are no complications and need for readmission, and escalate emergencies to the appropriate medical care. We also supporting NICU babies all throughout the country on post-NICU discharge with NICU nurse practitioners, helping parents to care for that little preemie baby that just came home and nobody knows how to care for. Reducing the need for that preemie to go back to the hospital multiple times or showing up in the emergency room since the parents don't know how to well care for them. Again, infant support all the way till 12 months of age, and after our urgent care is some of the services that we provide as an extension of care teams only to FQHCs and primary care organizations. The benefits, of course, are many, but on the economic, operational, and strategic side, reduction of ER utilization by having our services implemented is quite significant. Postpartum readmission or any readmission has definitely been shown reduced with our programs. We know that it reduces the in-person exam load, the daily message loads, and the reduces the clinical personnel that are needed to manage this population is being helped by our organization. Again, if we are able to do a lot of services in the patient home, we don't have to crowd your waiting room and increase the load of your personnel. Ultimately, strategically, of course, this is something that parents want. They do not want to come to your clinic 23 times. They don't want to be driving an hour and a half in LA traffic or getting on a bus and drive 120 miles to get to your clinic. Bringing this care to their home is appreciated. It reduces their financial and socioeconomic burdens, as well as the fact that they can keep their jobs and still be seen and being cared for. Baby Life Advice is open from 6 a.m. to 11 p.m. at night, 7 days a week and all holidays. That definitely allows patients different kind of access in their language and at their home. We also have our telemonitoring system where we can monitor chronically ill patients for diabetes, hypertension, and obesity, allowing us to then keep an eye on mother and baby for the healthcare organization, escalating only emergencies to you. This is the AltaMed program and what it looks like. We are very proud to have joined with AltaMed back in September of 2021, creating their own white label platform and capacity to download an application with multiple providers caring for patients in Spanish and in English. But we also have a translation services to 250 languages. The AltaMed program has been a big success program for any FQHC. And I do want to remind you, this is the first of its kind maternal health, telehealth in an FQHC that has been done in the country. There is no such program in the country. This is a first of its kind. So obviously having Dr. Nevares taking this on is been quite a challenge, but also quite a revelation in the fact that FQHC and women in FQHC who are low socioeconomic status, Hispanic women can and do telehealth, and they were doing it well as well. In this partnership, AltaMed is using Baby Love Advice for CPCA services. Total pregnancies at AltaMed are 5,400 a year, with total birth of 3,300. CPCA eligible is 58% of that population. Our appointments are being made by the CHWs directly into the program. And so it's very easy for a patient to just receive an appointment link and go into a telehealth visit from their home. Total patients served for AltaMed since September of 2021 is 2,650. Appointments were 4,820 and total group classes was 252 with massive attendance into group education of a total of 13, almost 1,400 patients. This is definitely showing that this program is viable, that yes, we can do telehealth in an FQHC for this maternal population and it will succeed. And that is by itself is quite a revelation for us. 61% of the patients that we are serving are speaking in Spanish. Of course, with that, 61% of our providers are Spanish speakers as well, to allow patients to speak, directly in their languages. We also, as I said, have other languages that are being represented, like Korean, Chinese, and some of the Arabic languages as well. 68% group class attendance is quite high, very hard to replicate in a face-to-face situation. 95% satisfaction across the board by the providers and the patients, and month-to-month engagement with our program is at 78%. Women will come back to this program as much as they can to get the services that they like at their home and at their language. We had a total of a lot of survey results that we have pulled from the patient. We are constantly surveying the patient population to make sure that we are exceeding their, care. Of course, what we have seen is that patients are very happy to receive these services. So satisfaction is always high, but we have seen them scored significantly higher when they started with us until the end. So we score them in the beginning to see how they're doing with health responsibility, exercise, nutrition, and interpersonal support. And then we score them before they leave the program. And we've seen a significant increase in all of these areas with our support. The participants report behavior changes. They're saying that they're feeling that they really well communicate, that they have the capacity to communicate with their providers. They felt confident. They're feeling that they will recommend this service to a patient or to a friend. And of course, the women felt very confident about the birthing option, knowing what they can and cannot do. We also talked to women who were pregnant, who did not want to continue with the pregnancy and had a lot of questions around termination of pregnancy, and knowing what their options are is also extremely important. 66% of the population in AltaMed is breastfeeding, at least beginning to breastfeed and staying breastfeeding within the first 2 months of life. That is an incredible support that is coming through the lactation consultation at their home and virtually. 62% of the women support receive pre and post depression screening. And the wonderful is that we can escalate to AltaMed with women who are severely depressed. And of course, all of them are saying that, another one good one is our support with vitamins. 92% of our populations are taking vitamins, iron, and folic acid, which is really wonderful. Before we go into some questions for Dr. Nevares, I just want to summarize everything that's been said here today, which is a lot. But do remember, influx of patients into Medicaid and Medi-Cal program will continue, especially as we take in undocumented immigrants into the Medi-Cal programs in the next few years, and as the population in California actually increases. Nursing and staff shortage, we know will continue. I am working with the ANA and other organizations, and we know that nursing staff is predicted to continue and increase for the next 10 years until nursing school will catch up with the demands. Innovation designs and models are really developing rapidly under FQHC, and it's time for FQHCs and other care organizations to start taking those on. There's a lot of laws that are changing, parity laws, payment laws, and telehealth laws are changing in our country to allow that to happen. And it's time to look into those programs. Health technologies are involving solving critical gaps in care. Today, 92% of California residents have a cell phone. 92% of California residents are with a cell phone that allows them to get care through their cell phone. And partnership with third-party providers can support operations. While you reduce your FTE requirements, remember that this is an extension of care team. This is something that can help. It doesn't take anything away, but can definitely help more in serving these populations. With that, before we go into questions, thank you so much. Again, my name is Sigi Marmorstein. This is my email. And if you need any other questions for us, we'll answer them at the end. Thank you so much.
Thank you very much, Sigi. And thank you, Dr. Nevares, for a great presentation, a lot of really rich content that you shared with us. We'll just take a few minutes to maybe ask some questions of Dr. Nevares, try to get an understanding of why you chose this particular platform and what the challenges were. And then we'll open it up to Q&A from the audience. So Dr. Nevares, you kind of already talked about your patient population and some of the challenges that existed, even in the urban community of Los Angeles and Orange County. But for you, what were kind of the drivers to seek virtual solutions for AltaMed as opposed to traditional in-person services?
Thank you. Yes, it was, first of all, it was in the middle of COVID. And we had the opportunity. We were going to be reimbursed, and I think it's probably the most brilliant thing that ever happened. There's a lot of bad things that happened because of COVID, but this was a particularly good one. We didn't have the opportunity to use this technology because we weren't reimbursed, and like everyone else, we're on a tight budget, especially with the FQHC population. I had an informal kind of study where I used to work, and we came up very similar numbers that every patient we had, women, either had a cell phone or had one degree relative that could manage a smartphone in the 95th percentile. So I said, well, if 95%, not percentile, 95% of women can actually access telemedicine, I thought, let's go for this. Also no-show rates, and no-show rates I think Sigi covered beautifully. It may be urban, it may only be a half mile away, but you have to have a car, or you have to take a bus, or you have to brave the traffic, which in the, when I first arrived in LA, you get anywhere in 20 minutes, and now it's closer to an hour. So we were faced with many of the logistics that, like I said, even rural America faces now, although I understand Northern California is getting rather congested as well. Sorry, I still think it's worse down here. And social determinants of health. We're working with the population that's almost not quite 100%, but it's 95% Medi-Cal, Spanish speaking, and trying to develop the healthcare team that can get to this population and feel comfortable and give the time, which I do have to thank Sigi and the people who worked with Sigi, with her. To our patients, we have uncovered more issues of health than we had without her. So I'm really grateful for bringing that up, and we've increased the amount of solutions we try and bring to this population because those problems came up and we realized we need more work. So those were the drivers, and not just the drivers, but the opportunities that we had to go into telehealth.
Okay.
So your other question, go ahead. You had other questions, like why
Yes.
Sigi?
Yes.
Why Baby Live? Yes.
Yeah, exactly. Why Baby Live advice? Did you look at other solutions?
We looked at about 5 different solutions that looked promising. Some were at different stages of development. Probably the thing that stood out the most was the question I asked her. I said, are we just working on algorithms? Are we working on, or are we working on licensed providers? And her answer was, we are working with licensed providers. Now, the fact that she'd done this before and she had quite a background in this is obviously was a clincher, but I was willing to go with this program because I had seen lots and lots of programs where, even with monitoring hypertension, with other monitoring systems, they did not have the depth of licensed providers. And I think that's important. And important in even giving the classes. We also know that locally, our CPHWs are busy. They're always busy, and we had run out of appointments. We had just run out of appointments. These classes are long, but I needed to increase the workforce really fast, and so this Baby Live was able to do that for me, with me, and it seemed to have benefited our patients significantly.
Okay, and I think we have a few questions in the chat, so I'll maybe just ask you maybe another 1 or 2 questions before we open it up to audience Q&A.
Sure.
But so I think it was mentioned, or I learned that to date, over 3,200 unique patients at AltaMed have been served by Baby Live advice. So how do you kind of feel that this has helped your organization to better manage maternity and maternal care for your patient populations?
Well, it's expanded us. I mean, we are still just as busy. It was amazing because most of our OB care was done through contracting. And when I hired the first 2 OBGYNs, I immediately had to hire 2 more. And then I had to hire 4 more, and then 8. And it's amazing what the unmet demand was. And I was very, very impressed with the growth of our program in all levels, including our pregnant education. So Baby Live increased, virtually increased the workforce very quickly, and was well received by our patients. And because of the hours that Sigi gave you, our patients didn't have to take our buses. The social determinants of health that we keep talking about, they're very, very real. And we assume that this population does better with a face-to-face. They don't necessarily all the time. It has to be there. I mean, you can't get rid of face-to-faces. You have to have the hands-on. But I was really, really impressed how our net was cast more widely for solutions when we included Baby Live. And Sigi and I communicate maybe every 2 weeks. And she communicates with our clinics, and she communicates with our staff. Patients that have communicated with their educators will often call them back when there's an issue. And fortunately, Sigi's able to circle that back to us and loop us back. And but it is truly an extension of the care that we are given. And I think it has to do with the fact that everyone's licensed. So that it's working better. It's extended the provider group, and picked up cases that are just real near misses that I'm very grateful that and can honestly say we maybe saved lives, but definitely saved serious situations and maybe even some hospitalizations. We didn't go into that, but that has more to do with the linking that occurs with the educators who are licensed. So they often end up getting put in a position where they're having to deal with real medical issues.
Okay, and one more maybe quick question, if you can, so that we have enough time for the audience Q&A. So you mentioned that AltaMed was able to kind of hire a number of OBGYNs, right? And you grew from 0 to 14 in the 3.5 years that you were there. But what advice would you give to health centers that might be a little smaller, maybe not as able to grow their workforce? But what advice would you give to them, to other FQs or other health centers that are seeking kind of similar solutions?
Yeah, well, the solutions that we had to come from came out of necessity and invention. Like I said, I had spent 40 years working in a closed system, but we had it really well organized. There were laborists. Well, there was our time to be in labor and delivery. There was our time to be in the emergency room. There was scheduled surgeries, and there was the clinic. So contracting out to private individuals who are trying to do all three at once, to me seemed like it would run in fraught with issues. So I broke it all up and worked with a really different, wonderful community. We still deliver at greater than 10 hospitals because, as you know, OBs can go wherever they would like. And so they do. But we've narrowed it down probably to 5 separate hospitals. We've organized the work so the people I hire are working pretty much just 8 to 5 scheduled work, and then we have contracts for our laborists, and any surgery we can schedule, repeat C-sections, GYN surgeries, etc. We do. But we've stopped some of the running in and out of clinic in the middle of surgeries or etc. By developing really good community partners. But it was tricky. What can I say? And remains, we're constantly being vigilant of putting these programs together.
Thank you. I will now turn it over to Charlotte, who will kind of ask some of the questions that we have from our audience.
Thank you, Ekama. And you just shared with me a document, but I'm not able to download it. So if you can put that in the chat to everyone, that would be great.
Okay.
Sigi, I did see that you were responding to some of these questions. So we have one that says, who provides the supplies, appliances for patients to take their vitals remotely? And it looks like Medicaid through DME company provides that. What is the cost of these services?
So the services are reimbursable. And so, yes, somebody asking here if AltaMed is billing for the services, the answer for that is yes. CPSP services are billable. And so we are not billing ourselves for our services. AltaMed is billing for our services. And we have an arrangement with the FQHC for a set rate for the services that we provide. And they are being billed to the FQHC once a month. And get reimbursable that way. So there is no cost to start this service. So we are really removing the barrier to get it started and to just get going and help mamas out.
Great, thank you so much. The other one is Baby Live available to chart in the FQ's EHR?
So we have our own EMR system that is integratable through HL7 to any EHR system. We are able to provide our SOAP notes into the patient chart through HL7 integration if the FQHC has that. We don't actually chart into the patient chart, but we are able to transfer a SOAP note into the patient chart, which is, all usually anybody needs.
Great, thank you so much. So that looks like let's see. So to follow up on that question, but what does it cost? AltaMed bills, what do they pay Baby Live Advice? What credentialing by AltaMed? Or are you
Yeah.
credentialed by AltaMed? Sorry.
So to explain the actual arrangement here is, yes, Baby Love Advice is licensed under Medicaid in the state of California. And we roll our NPI under the FQHC tax ID so they can bill for our services. So it's a soft credentialing of just the NPI. It's a third party like you use in any other third party, whether it's pharmacy, dental, mental health, it's the same kind of arrangement. And then, yes, it's being billed by AltaMed. And then we are just have an arrangement for a flat cost fee between us. And I know that that's very granular, but I'd be more than happy to go into, you know, each organization, different, arrangement. AltaMed obviously is a very large health organization. It's also an MSO. So very different than any other situation. So every situation to itself. The greatness of Baby Love Advice is that we will work with your organization. We will create a needs assessment, look to see what the needs are, which services do you require, and then look into financial arrangement that fits your budget and your needs and your billables.
Great, thank you. And then one last question before we close up today's session. Group classes for CPSP, you can only get reimbursed for one patient. Is that the same for telehealth?
So CPSP actually provides, under CPSP, a patient can receive up to 76 units of group education. Each one of our classes is allowing you to bill for one patient for all up to 76 units. And yes, we can do all of them.
Great. Thank you so much. And thank you to our presenters and all of our attendees today. When you exit today's session, you will be prompted with a brief evaluation. If you could fill that out for us, that would be great. If you do not get prompted for it, I have also copied it into the chat that you can grab it there. But everyone, happy holidays. Stay safe, stay healthy. And we will, I don't believe we have many trainings left, but if you have any more on your calendar, we look forward to seeing you there. If not, we'll see you guys all next year.
Thank you very much.
Yes, and a special thank you to our presenters today and for all of the rich content, and thank you to our audience as well. Happy holidays, everyone.
Happy holidays, everybody.
Thank you.
Bye-bye.
Bye.